I will be speaking on the preferred practice pattern in cataract with PDR. As already mentioned, the diabetic patients are 2 to 5 times more likely to develop cataract, and that too at an earlier age. So the early recognition and treatment of diabetic retinopathy before the cataract surgery influence the final visual outcome. Now, what are the conditions we are associated with the cataract we need to deal with? One is the tractional retinal detachment, another is the persistent vitreous hemorrhage, and neovascular glaucoma. So we can get 5 scenarios. One is the cataract with PDR, cataract with vitreous hemorrhage, cataract with TRD, cataract with neovascular glaucoma, and cataract with no visibility. DME been excluded from here and already been discussed by Dr. Ghosh. So in the first scenario where there is a cataract with PDR, if the visibility allows, we need to do the PRP in 2 to 3 sittings. If the lens opacity precludes a preoperative PRP, it can be administered as indirect PRP immediately or 1 week after the cataract surgery. Uncomplicated phacoemulsification does not lead to DR progression as thought so. If there is a progression, it is mainly due to the poor glycemic control. Now, this is a condition, there is a quiescent retina after PRP, after cataract surgery, recovered to 6/6 vision. Now, coming to the second scenario, that is cataract with vitreous hemorrhage. First of all, we need to rule out the tractional retinal detachment. The combined cataract and the vitrectomy surgery with endolaser photocoagulation, obviously PRP needs to be done for preventing the rebleeding. And presence of the pre-existing PRP scars associated with better visual outcome following PPV for vitreous hemorrhage. There is always a conception of giving intravitreal injection in a vitreous hemorrhage patient. It is known that the injection bevacizumab results in a rapid regression in the retinal neovascularization as early as 24 hours. There are several small retrospective reports which shows a role in resolving the vitreous hemorrhage. So there was a study, randomized control study in drcr.net protocol N, which compared the anti-VEGF versus intravitreal saline in eyes with vitreous hemorrhage precluding PRP, and it showed there is no difference between intravitreal saline and anti-VEGF. So presently, only preoperative adjuvant to PPV we are using intravitreal anti-VEGF, but not in cases of vitreous hemorrhage. Now, there are some surgical pearls in dealing with such situations. Especially, we need to be cautious while lifting the posterior hyaloid membrane. It is 100 times more adhered. Intraoperative bleeding to be controlled by elevation of infusion pressure and endocauterization. With wide field viewing system, the retina should be ablated up to ora. Obviously, this is possible with a wide field viewing system. And when cataract limits the visualization of the posterior segment or to spare the patient from the second surgery, combined surgery can be planned. Now, rendering eyes with severe PDR, pseudophakic or aphakic, there is an increased chance of NVI and NVG. Coming to the third scenario, the cataract can be associated with the tractional retinal detachment. Either the tractional retinal detachment is an extrafoveal one or involving the fovea. Now, if the tractional retinal detachment is more than 6 months, it is associated with photoreceptor damage. We should be keeping in mind. So whenever the fovea is involved, we need to intervene. We need to do the surgery. Broader areas of adhesion, there is a chance of membrane reproliferation. So vitreous should be dissected as far as possible. But in case of extramacular TRD, observation is the best way to do, because it has been seen for many years it can stay like as it is, the extrafoveal doesn't progress much. Whenever there is a fovea is threatening, then only we should intervene. And compared to gas and silicon oil is better in preventing the recurrent bleeding. And with the latest technologies of viscodissection, with the use of curved scissors, segmentation and delamination, we can give a better visual prognosis in this patient. Combined cataract surgery has an advantage of faster recovery, better post-op visualization of the retina. but it is associated 4 times higher incidence of NVG in high-risk eyes. So in high-risk eyes, the cataract can be performed later if possible. Now, use of intravitreal anti-VEGF, as I was mentioning earlier, it causes involution of the new vascularization, and the common practice now is to do the vitrectomy within 1 week of injection to get the maximum anti-angiogenic effect. We need to take care before giving the anti-VEGF in cases of TRD, because there are certain cases where the TRD is bad. It can lead to crush syndrome. What is it? With giving the anti-VEGF, the vascular component decreases, but the fibrovascular proliferation increases and leading to worsening of this TRD. So crunch syndrome should be kept in mind before giving intravitreal in cases of TRDs. So this is one of the cases where the combined RD and DR, the visual acuity improved from finger counting 4 feet to 636 after 6 months. This is a small video where the combined surgery being performed in a non-resolving vitreous hemorrhage. We can put the pods before the cataract surgery, or it can be done after the cataract surgery. It depends on the comfort level of the surgeon. After putting the pods, the other one is a valved cannula, so the plug is not been put. So once we are through with the cataract surgery, some basics of the vitreous surgery in a PDR. We need to truncate the posterior vitreous cortex instead of doing a forceful PVD, which actually can induce some iatrogenic break, because we don't know whether the vitreous hemorrhage is adhered with the underlying membrane. As in this case, we can see a small membrane is there nasally, not a big one. Once we clear the vitreous hemorrhage, we can see the membrane, a small one, just inferonasal to the disc. And with the forceps, we are just peeling out the membrane. Obviously, in extensive cases, extensive membranes, we have to do a cutter delamination and desegmentation and segmentation to prevent iatrogenic breaks, and do a good laser to prevent the rebleeding. The last case is the cataract with NVI. The prompt treatment with PRP induces regression of the new vessels before the cataract surgery, but after doing the PRP, if there is NVI persisting, then we can give anti-VEGF, because anti-VEGF causes a dramatic regression of the neovascularization, whether you give an intracameral anti-VEGF or an intravitreal anti-VEGF. Phacoemulsification with or without TRAB and vitrectomy should be considered earliest once the NVI regresses to enable the treatment of posterior segment pathology. However, visual outcome following phaco in eyes with NVG are usually poor. TRAB with antimetabolites, stents, glaucoma drainage device gives a poor success rate. There are few reports where the subconjunctival injection of Avastin has been used for rescuing the failed filtering blebs, but standardization needs to be investigated. Combining phaco with endoscopic diode laser photocoagulation is the last option. So to conclude, with careful pre-treatment of diabetic retinopathy and minimally invasive cataract technique, visual recovery is possible. Scattered pan-retinal photocoagulation remains the mainstay of treatment when view allows in PDR. Intravitreal anti-VEGF has no primary role in vitreous hemorrhage, but may be used, may be an useful adjuvant before doing an pars plana vitrectomy. The current practice, if there is no improvement of vitreous hemorrhage after 4 weeks of observation, the majority, that is 80%, benefits from the PPV. Obviously, there are some bad prognostic factors like macular ischemia, long-standing DME, and NVG. Thank you.
Thank you, Dr. Maiti, for elaborate speech. And our next speaker is